Awesome. Well, welcome back, everyone. Hope you had a nice little break. We'll have a few more throughout the day. So it's now time for our first keynote speech by Dr. Brenna Maddox. She is both an academic and a clinical psychologist at the University of North Carolina in Chapel Hill. She's also the deputy editor for the journal Autism in Adulthood and has worked on knowledge translation aimed at including autistic adults in the development and delivery of clinical training programs, which is just awesome. As I said, I'm a clinical psychologist and I definitely didn't learn enough about autism in my training. So over to you, Brenna.
Hello, I'm so honored to be here today with you all virtually. And I want to thank the conference organizers for putting together this incredibly important and timely event. And thank you for inviting me to be part of it. Wish that I were there with you all in person, but we will make the most out of this virtual experience. And I'm excited to answer your questions live during the Q&A period. First, a quick note about the language that I will be using in this presentation today. Personally, I was trained in graduate school to use person-first language or person with autism as the most respectful and preferred way to refer to individuals on the spectrum. And so I used person-first language for many years. And then more recently, my close autistic collaborators, the people that I work with on several projects, some of which you'll hear about today, express their preference for identity-first language or autistic person. And there have been several articles published in the last few years that highlight the preference for many people on the spectrum of identity-first language. And so I just want to note before I jump into all my slides today that I will be using identity-first language to respect that preference. For anyone who's interested in reading more about this use of language and how to avoid ableist language, I would highly recommend checking out this article published in Autism and Adulthood last year. So why are we all here today at a conference focused on suicide prevention for autistic people? As you all know, we're focused on this topic because there is a growing awareness that suicide is a leading cause of early death in the autistic community. The prevalence of suicidal thoughts and behaviors are significantly elevated in autistic children, adolescents, and adults compared to the general population. This new article just came out a couple of months ago by the time of this conference. It's already getting a lot of press, which I think is good, again, to increase that awareness. And this paper is a systematic review and meta-analysis of 31 studies. And it finds that the odds of self-harm in people on the spectrum is more than 3 times the odds in people not on the spectrum. And this article is really, as I mentioned, raising awareness, again, that both children and adults on the spectrum are at this increased risk for self-harm and suicidality. So knowing the elevated prevalence estimates, I think a natural next question is why, right? What makes autistic individuals more likely to think about, attempt, or die by suicide? We know that factors known to increase the risk of suicide in the general population are more common in autistic individuals. And I've listed just a few examples up here on the slide. However, in studies that have had comparable rates of some of these factors in the two groups, an autistic group and a non-autistic group, even when these factors are similar across the two groups, the autistic individuals still show an increased risk of suicidal thoughts and behaviors. And of course, this suggests that we need to consider additional factors, and some may be more specific to autistic individuals. So this list of risk factors of suicidality is in no way an exhaustive list, but some of these risk factors are the most studied, the most supported as risk factors, and also some that may be specific to autism. This first one, I'm sure, is not a surprise to anyone listening. Co-occurring psychiatric conditions in autistic individuals is a significant risk factor for suicidal thoughts and behaviors. There was a large national study out of Denmark earlier this year, and the research team found that of that group of autistic adults who either attempted or died by suicide, more than 90% of them had a co-occurring psychiatric condition. We also know that a lack of social support and similarly, or more generally, unmet support needs can be a risk factor for suicidality in autistic people. And Dr. Headley and Dr. Cassidy and their teams have done some really wonderful work to show and to highlight how these risk factors need to be better understood. Camouflaging or masking is somewhat newer in the literature, getting attention as a potential risk factor for suicidality. The next one up here is a late diagnosis. So we know that individuals who receive their first time autism diagnosis in adulthood are at an increased risk of suicidality. Several studies suggest that autistic females are at a particularly increased risk for suicidal thoughts and behaviors. And then this last one, autistic burnout. Again, this is a somewhat newer term in the field, and it's defined as a syndrome conceptualized as resulting from chronic life stress and a mismatch of expectations and abilities without adequate supports. And if you're interested in learning more about autistic burnout, Dr. Raymaker and colleagues published this excellent article in the journal Autism and Adulthood last year, and they really describe, define, and summarize the potential negative consequences of autistic burnout, including suicidality. So we were just talking about risk factors, which are characteristics or conditions that make it more likely that individuals will think about, attempt, or die by suicide. Warning signs, on the other hand, indicate a more immediate risk of suicide. And unfortunately, there is much less research in the autism field right now on suicide warning signs compared to risk factors. To hopefully start to close this gap in the research, and particularly in terms of practical guides, Lisa Morgan, whom you're about to hear from in this conference, had the brilliant idea to develop a proposed set of warning signs for autistic people. And as I'll show on the next slide, she invited a small group of us to work on this guide. This was just recently published. I have the link there on the slide. That is Lisa's website. And this new Warning Signs of Suicide in Autistic People resource is featured on the main page of the website. And as you can see here, this is a resource that's based on research findings and expert consensus. And our motivation to develop this resource was that warning signs of imminent suicidal behavior in the general public do not always represent the unique needs of the autism community. And so, as I mentioned, Lisa had this wonderful idea to pull together an international group and brought us together to work on this resource, the development of this resource from July 2020 all the way until August 2021. And so you can see the co-authors are pictured up here: Dr. Teal Benavides, Dr. Mary Donahue, Dr. Sarah Cassidy, Mirabelle Pelton, and myself. All work closely with Lisa Morgan to develop this resource. And one thing I really admire about this team is that we cover a wide range of experiences. Many of us have multiple experiences and roles, including autistic people, researchers, practitioners, and those with lived experience of suicide loss and suicidality. This guide is designed to enhance discussions about suicide risk with autistic people. We want to make clear that it's not a substitute for professional support or professional risk assessment. The goal is to improve individuals' understanding. So this could be mental health professionals or physicians, it could be family members and friends, improving their understanding about these potentially unique warning signs of suicidal behavior in autistic people. And I think Lisa will touch on this more in her presentation, but we really went into this work together wanting to prevent both kind of sides of these devastating consequences that can occur when someone does not understand warning signs of suicide in autistic people. So misunderstanding a suicide warning sign in an autistic individual can lead to someone reacting and intervening without really understanding that what the autistic person is experiencing can be traumatic and can lead to unintentional harm. Then on the other side of things, if we don't recognize something as a warning sign and we don't act or we don't intervene, that of course can have devastating consequences as well. So our hope is that this resource will get into the hands of more people and help improve that understanding. A little bit of information about the structure of the resource. We proposed, again, based on research and expert consensus, a set of 10 warning signs. So those are listed, followed by brief scenarios or case examples explaining them, emerging research findings where available, because like I mentioned, there is not as much research in this area, unfortunately. We also have a few pages of additional resources about autism and suicide prevention, and then a one-page summary to use in real time. So you may be wondering, what are these warning signs? I do not have enough time today to go through all of these in depth, but I will list the 10 warning signs here on the slide. I do want to note that the warning signs are contingent upon a marked increase or change of specific experiences or behaviors that are different than usual for the individual. So this really highlights how important it is to get a good understanding of the individual's baseline. I also want to note that for many autistic individuals at imminent risk of suicide, more than one of these warning signs would be present. The first is sudden or increased withdrawal from typical activities or from social interactions. No words to communicate acute distress. So we're hearing this from more and more autistic individuals as an experience that they've encountered. They want to communicate that they need help, but they are at a loss of words to do so. A current traumatic event, a marked increase in the rate and or the severity of self-harm, a worsening of anxiety and or depression, a new focus on death-related topics that are not an intense interest for the individual. So we recognize that for some individuals on the spectrum, one of their intense interests may be related to death. I remember working with an individual who was really interested in researching the cause of death of celebrities. And that was something that we would talk about in most of our sessions together. It was not a new focus, and it was an intense interest. So we're trying to distinguish in this resource that you need to be looking for that new focus on death-related topics that are not an intense interest. We know that suicidal thoughts and ruminations can take a perseverative quality in individuals on the spectrum, and this is definitely something to look out for. Seeking means or making plans for suicide or suicide rehearsal. Statements about no reason for living or no sense of purpose in life. And then finally, hopelessness. So I encourage you all to read more about these warning signs from the free publicly available resource. And I want to thank the co-authors again for making this resource available. It was really, really inspiring to get to work with this group. And we're all excited to disseminate this resource more. So thank you for the opportunity to talk about it today on behalf of this wonderful team. Before moving on, I do want to provide one example of a case scenario from this resource. So this is the case scenario from sudden or increased withdrawal, and I'll read this to you now. Lucia routinely withdraws for self-care. Her family and friends understand the need she has for alone time. They know Lucia will be spending time in her room for a while after school, work, and social events, and then will immerse herself in making play animals. Suddenly, Lucia's family and friends noticed she was spending more and more time in her room. Lucia goes straight to her room when she gets home, only coming out for meals. She continues to participate in her usual activities, although she doesn't want to and takes longer to regulate afterwards. Lucia is no longer interested in making her clay animals, and she's not replaced that passion with another. So a few things to note about this scenario. Lucia, like many autistic people, values alone time to recover after intense social events. However, sudden or increased social withdrawal, which is unusual for Lucia, could indicate a mental health problem such as depression. It's particularly concerning here that Lucia's increased social withdrawal is coupled with her reduced interest in pleasure and a previously intense interest, making her clay animals. And Dr. Cassidy and colleagues have recently published some research that suggests that together, these are unique warning signs for depression in autistic people. And we know that depression can come with suicidal thoughts. Before wrapping up, I do want to highlight a few crisis supports and resources while we're talking about this topic of suicide prevention. Lisa Morgan, in collaboration with the American Association of Suicidology, or AAS, the Autism and Suicide Committee, published this crisis supports for the autism community, which is another free publicly available resource. The link, the link is up here on the AAS website. And the purpose of this toolkit is to help crisis center workers and other professionals in identifying and supporting autistic callers or texters who are in crisis. Autistica also recently collaborated with researchers, clinicians, and community members to create a new mental health resource for professionals supporting autistic children and young adults at risk for suicide. Another resource or intervention that I want to note here is the safety planning intervention. And Dr. Sherry Yeager-Hyman from the University of Pennsylvania and I received some funding from the FAR Fund a few years back to adapt the safety planning intervention for autistic adolescents and adults based on stakeholder feedback and based on the established modifications to cognitive behavioral therapy for individuals on the spectrum, because the safety planning intervention is a cognitive behavioral intervention. For anyone not as familiar with the safety planning intervention, or SPI, it's an evidence-based suicide prevention intervention in the general population. So it has not been rigorously tested for autistic individuals in the past. It's a brief, individually tailored intervention. And that individually tailored piece is a nice strength when working with autistic individuals. We can really tailor it to match that individual's interests and strengths and needs. And the version of the safety plan that Sherry and I modified is the Stanley and Brown version. So as we were wrapping up our FAR Fund study, PCORI, or the Patient-Centered Outcomes Research Institute, released a funding announcement focused on brief interventions for suicide prevention in youth. And they were specifically interested in tailored versions or culturally adapted versions for at-risk subgroups. And Sherry and I were delighted to see that PCORI recognized that individuals with developmental disabilities are an at-risk group for suicide. And so with a truly amazing team that I will highlight here in a moment, we proposed a large-scale comparative effectiveness study, and we are very excited that we'll be launching this study next month with the support of PCORI. So I want to end by sharing a little bit of information about that study, and I'm happy to answer any questions during our Q&A time. So this is a 5-year study And we are very fortunate to have the opportunity to partner with 4 different health systems here in the United States: the University of North Carolina at Chapel Hill, where I work, Kennedy Krieger Institute, the Children's Hospital of Philadelphia, and Nationwide Children's Hospital. And the main focus of this study is to compare the effectiveness of that tailored safety planning intervention with and without a structured follow-up component. And the interventions will be delivered as standard care. So what's exciting is that these health systems have agreed to adopt the tailored safety planning intervention as part of routine clinical practice. And we will be embedding the research activities into their routine clinical practice. The thing I'm perhaps most excited about is this community-based participatory research design. And one of the biggest honors of my career was when the co-leads of the Autistic Adults and Other Stakeholders Engaged Together, or ASSET group, reached out to see if I would be interested in partnering with ASSET on this PCORI proposal. And of course, I said yes. This is an amazing group, co-led by Dr. Stephen Shore, pictured here, and Dr. Teal Benavides, pictured here. Lisa Morgan is also part of ASSET, along with many other autistic adults and other stakeholders. And ASSET was created through a PCORI Stakeholder Engagement Award back in 2017. And they had funding for 2 years to work on this goal, to meaningfully include and engage autistic stakeholders in identifying priorities and methods to support patient-centered outcomes research in true collaboration with autistic people. So we talk a lot about authentic autistic alliance and meaningful involvement. And during that time, they established a community council. And what I think is so impressive is even after the PCORI Engagement Award funding ended, this group has continued to work together, to publish, to present together, and to drive this mission forward. And so it's, again, such an honor to be able to partner with them on this PCORI study. So this is my last slide. There's a lot going on this slide. It's a little visually overwhelming, so I apologize. I'm not going to go through all of it, but I just want to highlight what a big, strong team we have for this PCORI study on suicide prevention in autistic individuals. As you'll note here, we have a strong stakeholder engagement core that really is at the core of our team, co-led by Drs. Shore and Benavides. And the ASSET Community Council is a big part of that, as well as a multi-stakeholder advisory board. We also are excited and really fortunate to have autistic adults be part of our clinician training team and our implementation outcome evaluation team. And you may notice or recognize Lisa's name here. Lisa will be co-leading the clinician training team with us. So getting into those health systems, we're going to be able to train a large number of clinicians on how to best screen for, assess, and manage suicidality in autistic individuals. So we are really looking forward to getting started, and hopefully at some point soon we can come back and share some of those results with you all. So thank you so much for your attention today. I want to acknowledge the wonderful community partners, as well as academic collaborators who make this work possible and from whom I continue to learn so much every day. And of course, thanking the research participants who agreed to participate in these studies and the funding sources. And also, again, thank you to everyone in this audience for your attention. And I'm looking forward to answering your questions and hearing your thoughts during this discussion period. Take care.
Wonderful. Thank you so much, Brenna, for sharing with us today. We really, really value all of your experience and input. So we now have lots of time for some questions. So I would like to invite Brenna to join us for this question and answer session. So if everyone would like to go to slido.com, You can pop your questions in there. Now they can be anonymous or you can add your name, whatever you prefer. And the code for this little session with Brenna is 720731. So I'll just say that one more time, 720731. So you have Slido on the right side of your screen, I believe. So start popping in your questions. I will have a look to see what's coming in, and I've just actually had a look at some of the comments. I've seen people are joining us from all over the place. We've got people from UK, from New Zealand, from the US, of course Melbourne, some others in Brisbane. So thank you all for saying hello. So as questions start coming in, we'll just give everyone a little bit more time.
While we're waiting, I just want to say thank you again for this opportunity to be here. It's so wonderful to get to be here live with you all virtually. So thank you.
Thanks, Brenna. While we have some coming in, I might pop one in to start us off. So you mentioned autistic burnout, and I think that's such an important thing for clinicians to be aware of, whether they're in private practice or in emergency places. I think autistic people are often misdiagnosed with things like borderline personality and other things, but people don't realize they're burnt out and they need support. So I was wondering if you could give us more examples of what that burnout looks like and how clinicians who are maybe here today can recognize that.
That's a really good question. And as you were talking about that, I was thinking how for this Bacori study that I mentioned at the end of my presentation, that's part of what we're really excited about for the clinician training is, our team will be designing that training and educating the clinicians about autistic burnout will be a part of that training. So I agree with you that I think it's really important to improve awareness about what this is. It is a newer term that's out there, although I want to make clear that the experience isn't new, right? We just now have kind of a common term to use to describe it. So I think the paper I highlighted by Dr. Dora Raymaker and colleagues does a much better job describing what that looks like than I can. But I think what we would want to educate clinicians about is that this is something specific to autistic individuals and something that they need to be keeping their eye out for when they're interacting with someone, and something that we need to be asking about as well, right? And having some explicit questions when we're doing those initial screening or assessment interviews. We can be asking about burnout and asking about how that may be affecting someone's quality of life.
Yeah, I think it's so important, and it's great to hear there's more information coming out. So we've got some questions in now from the audience, so I'll start reading some out.
Excellent.
So we've got, how does anxiety fit into the picture in relation to autistic burnout? Thank you for that question.
Yes, I think that's a really good question. I think that it fits in probably in a variety of ways depending on the individual. So for some people who have high levels of anxiety and their environment or their kind of day-to-day routine is not accommodating or supportive of that anxiety, I think it could contribute to autistic burnout, absolutely. And then we also know that autistic burnout has negative downstream consequences, including mental health problems. So I think it could also increase anxiety. So the short answer, I think, is that they're very interrelated.
Yeah, definitely. That makes a lot of sense. I've read something recently that said, it sounds a bit corny, but if a fish is sick, do you fix the fish or change the water? And, if you fix a fish but put it back in the dirty water, it's just going to get sick again. And I think, that connection with anxiety and burnout is all about fixing the water, looking at schools, workplaces, the systems that's around them that's contributing to anxiety. So I think that's a really good point. So what else have we got? Someone has asked, I'm curious about insomnia. It's an independent risk factor for depression, suicide, and suicide ideation in the general population and is elevated in autism.
I'm so glad someone brought that up. It makes me think of some of the work Asset has published on related to some of the top priorities for autistic people, and knowing that sleep problems are very common and very impairing. I know other stakeholder groups have identified this as a priority as well for research. And so as far as I know, this is a factor that has not been studied extensively yet, specific to autistic individuals and suicide, but it seems like a really important next step. And perhaps a group is already working on that. But I think pulling on what we know from the general literature, and then pulling from what we know from the autistic community about how problematic sleep concerns can be, it makes a lot of sense to be looking at that more closely. I think that also, in my mind, speaks to why we have to think broadly about suicide prevention. This, in some ways, I think gets back to your point about the water, right? So knowing that autistic individuals are interacting with so many different systems. So I'm a clinical psychologist. I often think about mental health clinics, right? But you may be talking to a primary care physician about sleep. And so are the primary care physicians or other medical providers, are they getting training and education about suicide risk in autistic individuals, just as an example of another system?
Yeah, definitely. I think that's a really good point and makes sense. Sleep is so important and would really contribute to burnout, so very important to look at.
Absolutely.
We've got another question. Brenna, what are the benefits of co-production in your research?
Oh, how much time do I have left in this Q&A? Because I probably could talk for several hours about this. I will do my best to be concise, knowing that time is limited. This PCORI study is the most salient in my mind right now, because it was such a large lift to work on that proposal. And so I know people here, including Lisa Morgan, who you're about to hear from, remembers how much time and energy it took to work on that proposal and get that in. And so I'm going to speak about that experience because it is so salient in my mind. The benefits of co-production are truly more than I can kind of give a short answer to. I think I'm learning more and more, really each meeting that we have or each email communication, that there is very little that I can bring to the table solo. And that team process in learning from people, particularly people with lived experience of being on the autism spectrum and experiencing suicidal thoughts and behaviors, is really what we need to understand, right? What is going to be helpful for autistic individuals. So I think learning from people with lived experience has helped us make some really important changes, not only to the intervention in the initial phase, but also to our study design. I can give a couple of concrete examples as well. I think going into our PCORI writing process, we had some measures in mind for our constructs, and we heard from Asset that there were a few constructs, including quality of life, where we could not only have a quantitative measure, we really needed to dig deeper with a qualitative interview. And I would not have thought of that. I think I would have just proposed a survey and kind of called it a day. And I was so glad that Asset brought that up. And so now we have qualitative interviews as well to assess for quality of life. We'll also have autistic people leading those interviews. That was another thing that I will admit, I was not going into the grant writing process thinking about that. And I'm so glad that we have autistic people who want to lead those interviews and will also be part of the coding. So I think the benefits, I'm really focusing on the proposal development period. And then I can definitely see how it's going to continue to benefit this study as we launch.
That's brilliant. Thank you so
If
much.
I could share one other more personal example, Lisa and I were talking earlier, and I often co-present with Lisa, and during the Q&A time, I get to share some of my thoughts and then pass it to her or vice versa. And I'll be honest that I'm missing that right now. I really would prefer to have that kind of co-presentation and co-answering questions, because you're just hearing my thoughts or kind of my perspectives to some of these things. And really, I think you should be hearing about autistic burnout from people with that lived experience.
Yeah, definitely. No, it'll be great to hear from Lisa later. And we have a lived experience panel, which will be awesome. No, thank you so much for that. As you know, as they say, not about us, without us. So co-production is so important. So we've got lots of questions coming in. So your talk was all about warning signs. So this is good for carers and clinicians. How do warning signs in autistic people differ, and how do they differ from neurotypical people?
That is an excellent question. And that is what we were really trying to highlight in our new warning signs toolkit that I talked a little bit about, but you could definitely find more information in the guide itself. I think one of the main takeaways from our team's work on that resource is some of the warning signs don't differ, right? There's some things like hopelessness, making plans for a suicide attempt. These are warning signs kind of across the board. I think that in that guide, we do our best, again, pulling on the somewhat limited research and also pulling in expert consensus about what are some things that may differ. So for example, I, as a clinical psychologist, had never heard or really thought about this warning sign of no words or a loss of words to communicate distress. And I know from my work training community clinicians that they have talked about times where they missed that warning sign in an autistic person, because what they were seeing in session, neutral facial expression, no outward signs of distress, quiet, maybe even appeared to be peaceful, right? Or content. And it wasn't until the autistic person hopefully was able to talk about that at a later point and describe how in that moment they were actually at extreme levels of distress, and they did not have the words to communicate that, and just felt like they could not get the words out. So again, that's something that I do feel like is more of a specific warning sign to autistic people. Although of course we need research studies to say for sure about that. The other point I will make about that, and I think Lisa and our committee did a good job describing this in our considerations for warning signs toolkit, that really you just have to dig a little deeper oftentimes with these warning signs when you're working with someone on the spectrum. You want to make sure that how you're explaining, how you're asking your questions is very clear and concrete. And then, they may give an answer. And instead of just kind of taking that at face value, asking a couple of follow-up questions to make sure that you as the clinician are understanding the meaning or the intent before you make a decision in your head. Is this a warning sign, or is this something I'm just gonna kind of put to the side? So I think that would be my other take-home message, is just knowing as a clinician or a mental health professional that you may need to spend some more time asking for that information that you need to assess warning signs.
Yeah, that's awesome. Thank you so much, Brenna. I think there's some really good points there, especially that shutdown. I think a lot of people can mistake that for, oh, they're calm, they're fine. But, it's really important if someone seems unfazed by something, that would be difficult to still ask the questions about suicide.
Mm-hmm.
Okay, we've got another question here. I'm interested in learning more about the way safety planning can be modified to better meet the needs of autistic people. What are your thoughts on that?
Another great question. I really like all these questions that are coming in. Thank you. So the safety planning intervention, as I mentioned, is a cognitive behavioral based intervention. And so some of the modifications are pretty straightforward and have been applied across cognitive behavioral therapy programs. So these are things such as making the language more concrete, and taking out extra words. So basically making it more concise. And we had some really wonderful help from our stakeholder partners, including Lisa, to do that, where we would come back with different revisions of the safety plan. And there were still words that we could remove because it was just too many words on the page. And of course, as we discussed, when someone is in crisis or is distressed, having those extra words, it's just too much. It's overwhelming. So yes, making the language more concrete and concise, leaving some flexibility. The unmodified safety plan had numbered options for you to fill in with lines. So it was really pulling for words, written words. And so in the modified version, we have blank space without numbers, first of all, and also so that people could have pictures if they prefer that to written words or a combination. The original safety planning intervention has a pretty strong focus on social supports as an important coping strategy. And one of the consistent themes we heard from stakeholders is that sometimes having such a strong focus on social supports can not be helpful and could in fact be triggering when you're developing that safety plan with a clinician in the room. And so we really took what the original safety plan had as social supports with, I think the focus there was really on social supports from other people, and that is still an option, but you could also include support from pets or from objects, things that bring you comfort or could distract you when you're feeling distressed or when you think that you may be headed toward a suicidal crisis. So those are just a few of the modifications. I think that an important point I want to make is we didn't change the core components of this evidence-based suicide prevention intervention. So the core, or if you will, active ingredients of safety planning are still there. Recognizing warning signs, coping strategies, restricting access to lethal means, and having emergency contact information there readily accessible. So hopefully, as you're hearing me say this, you're thinking, well, it doesn't sound like those modifications are a big 180. And that is kind of the point, is we want to make it more accessible and more helpful in the moment, and really tailor it to the learning style of autistic people, but maintain some of those evidence-based suicide prevention strategies.
Awesome. Some really helpful tips there to modify and tweak things. Thank you. So we have about 5 minutes left, so a couple more questions we can squeeze in. So we've got one here. So lots of people are saying great presentation, and everyone's saying thank you so much.
Thank you. I cannot see those things, so thank you.
So someone has said about the signs of suicide, and many of these can be typical withdrawal that you mentioned, behaviors by adolescents as they separate from their parents. So the focus on these can cause alienation between parents and adolescents. So how would you suggest parents manage the conflict, this conflict best? So I guess typical withdrawal that's normal for adolescents versus as soon as they reflect.
Yes, that's another great question. And I don't know if I made this super clear in my presentation, but with all of these warning signs, we want to think about what is baseline, and then has there been a significant or notable change in that baseline behavior, because we know that many of these things, including anxiety, depression, withdrawal, things like that, could be part of an individual's life when they're not at imminent risk of suicide. And so I think for this question about adolescence and kind of maybe more typical with withdrawal and isolation from parents during that developmental period, I would think try to establish what is baseline and has there been a notable change. And think this may be a time to really, rely on multiple reporters of information. So getting a sense from the adolescent, if there's been a change in baseline in the last couple of weeks, and same from parents as well. And then, of course, oftentimes more than one of these warning signs will be present at the same time. And so keeping that in mind as well.
Awesome. Yeah, that's so good to be aware of the baselines to compare to. Well, there's a few more that we won't have time to get through, but for those who haven't had their question answered, check out the conference booklet. Brenna's contact details are in there. Chat with each other in the chat function. So hopefully everyone can still keep engaging. Today's just the start. So thank you so much for your presentation and for taking the time to answer these questions. It's been great to hear and learn from you. So it's now time for a break. So we have about 5 to 10 minutes. So let's aim to be back here about 10:30. So I'll see you back here soon. Thanks, everyone.